Actually, our next speaker is our esteemed pharmacist who's just been dedicated to her program and has truly, yes? There's a question there.
So far, no questions on Zoom. Just updating you.
There's no questions on
No
Zoom?
questions so far.
Oh, thank you. Perfect.
You're welcome.
Okay, good. Perfect. So James has really developed an expertise in our patient population and in partnering with us to decrease the medication-related bad outcome that can occur after post-transplant. So we're going to talk today about overcoming non-adherence in the underserved population. Thank you so much, Jane.
Thank you for the introduction. Prior to starting, I have no conflicts of interest to disclose. So at the end of this presentation, hopefully we will all be able to define non-adherence and explain the risks in our transplant candidates, understand pre-transplant pharmacologic evaluation process, identify certain barriers to adherence in our underserved populations, discuss medication adherence strategies, and we will go over common immunosuppressive medications post-transplant and associated adverse effects. So prior to transplant, evaluation of adherence in the pre-transplant candidate is very important. And usually in many centers, it's recognized as a relative or absolute contraindication to transplant. Psychosocial evaluation is usually performed by our social workers, and this is an essential part of the pre-workup process. Pharmacist evaluation is also performed in our patient population as well, and if any non-adherence is identified, we usually try to partner with the patient and we try to enforce a minimum of a 6-month demonstration of adherence to therapy. Now, non-adherence doesn't always factor into medication non-adherence. There's also non-adherence when it comes to making appointments, making their dialysis sessions, or even adhering to nutrition guidance that has been previously provided by the providers. Some issues with non-adherence or the patient populations that are at highest risk of non-adherence are those of low-income patients as well as minorities. We will talk a little bit about the consequences in later slides. However, it's important to recognize that the patient population that we're working with does have a high incidence or prevalence of non-adherence. In terms of definition, the World Health Organization, or WHO, defines adherence as the degree to which a person's behavior corresponds with the agreed recommendations from a healthcare provider. Now, these agreements to recommendations usually comes in a shared decision-making process and innovative strategies that focus on patient-centered goal setting for up-titration to guideline-directed medication doses designed to achieve optimal therapy benefits. And beyond medications, like I mentioned earlier, these also include clinic visits, exercise, diet, and blood tests. And the word adherence usually indicates a more collaborative partnership between the clinician and the patient. We often also hear of the word compliance, and this is often used interchangeably. However, compliance indicates a more passive role where patients is just following instructions given by the clinician. What are some consequences of non-adherence in transplant? So research has shown that up to 1/3 of our kidney transplant recipients may be non-adherent to immunosuppressive medications. Studies report that every 5 years after transplant, cases of non-adherence increase by 20%, and that's quite a bit. This non-adherence is responsible for up to 20% of antibody-mediated rejection. It's related to 16% of early graft loss, and there is also a significant economic impact where there is an estimated of $15 to $100 million annually that needs to be dealt with in the healthcare system due to non-adherence, specifically in the transplant population. In terms of measuring non-adherence, how do we measure non-adherence in terms of quantitative assessments? So there's taking adherence versus timing adherence. So as a provider, when we measure non-adherence, taking adherence means measuring the percentage of medication intake that is done by the patient. So for example, If a patient's supposed to be taking medications twice a day, 7 days a week, but they're only taking it, for 5 days a week, we take a percentage of the medication intake based on how many times they're supposed to be taking their medications. Whereas timing adherence relates more to percentage of correct interdose intervals. So for example, if they're supposed to be taking medications twice a day, 12 hours apart, but they're missing the 12 hours mark, and they're prolonging their medication intake to 15 hours or 16 hours, this relates to timing adherence. Both taking adherence and timing adherence is very important in our transplant population because there are some medications that we do take levels on, and so if the patients aren't taking it in the correct time, the levels may be skewed. So both of these need to be taken into consideration with our population. Some factors contributing to non-adherence include medication costs. So this is pretty prevalent in our population. And we'll talk about some ways to overcome these non-adherence factors, but busy schedules that make it hard to remember to take medications consistently is another factor contributing to non-adherence. Scheduling appointments or lack of ease of scheduling appointments can lead to non-adherence. The time needed to schedule and attend appointments, especially for working adults, that may contribute to non-adherence due to difficulty in making these appointments. Ease and comfort level of communicating with the pharmacist or other providers. Understanding when and how often to take medications. Ability to sync medication and receive automated 30 days or 90 days refills so that the patients aren't running to the pharmacy every other day to get their medications. Health condition severity and beliefs about their conditions, so how well they are educated about their health condition and what they truly believe about taking medications on time for their conditions. And expectations around possible side effects of the medication is also a contributing factor. So while many contributing factors that we just reviewed do occur at a patient level, however, there's also prescriber level and health system level of contributing factors as well. And we'll go over how to deal with these contributing factors. So in terms of interventions related to pill burden, so as providers, if we're recognizing that a patient is potentially having issues with adherence due to the number of pills they are taking, there are certain things that we can do, and these include decreasing medication frequency to daily dosing if possible. So using extended release formulations, for example, to help decrease that pill burden, discontinuing unnecessary medications, and then requesting blister packaging. So blister packaging is basically when the pharmacy is able to pre-pack the patient's medications for them so that all they need to do is open up the blisters and take all their medications at once. So this is something that we can do to decrease pill burden as well. In terms of interventions related to cost, some things that may be helpful is for medications that may be expensive and we're not sure if it's covered fully by the patient's insurance, we can try to obtain pharmacy costs before prescribing the medications or sending the patients out to go pick up the medication. Work with local low-cost pharmacy programs. So there are pharmacy programs in New York City that work with the low-income population, and also making discount cards and patient assistance programs available. Now, this one's quite important, interventions related to health literacy, especially in our population who may have a lower health literacy or understanding about their health conditions overall. So involving family and other caregivers in medication education is one of the interventions. Referrals to community social work or community resources to help get the patients involved in support groups, for example. Making referrals to home health for medication adherence education. So if the patients have a home health aide, getting them involved. Provide written medication lists with a scheduled grid. So we do this for our transplant patients. We provide a medication chart for them before they leave the hospital. And I think this is a lot more helpful than giving them a whole list of medications. And providing medication education appropriate to the patient's health literacy. So this basically means kind of speaking in layman's terms and meeting the patient where they are in terms of their understanding about their health condition and about the medications, and simplifying a lot of the terms or even simplifying the schedules to meet them where they are. Interventions related to follow-up care, so scheduling in-person follow-up within 7 days of discharge. We also do this as well here. Scheduling pharmacy home medication delivery. This is something that we're still working on. However, our pharmacy is starting to deliver medications to the patient's homes. Sharing care summaries with other care providers, as well as scheduling a phone appointment follow-up within 1 to 3 days of discharge to check in on them, seeing if they have any follow-up questions or last-minute questions now that they've been home for a few days and having to deal with their medications on their own. So with that, I do want to touch upon common immunosuppression medications post-transplant. This will be a brief overview summary. And of course, as with any medications, there are benefits versus risks of immunosuppression agents. So benefits, of course, are to prevent rejection, improve graft function, and increase quality of life, as are with the goals of transplant overall. However, there are risks involved, especially as these immunosuppressive agents are quite potent. There's often malignancy, infection is a great concern, as well as toxicities or adverse side effects that needs to be managed. What are the goals of therapy in immunosuppression? So we want to prevent acute and chronic rejection. There are different stages at which rejection can occur throughout the post-transplant patient's post-op course. So hyperacute, acute, or chronic. Hyperacute can happen within minutes to hours post-transplant, caused by preformed antibodies against the donor. This is now rarely seen in current practice due to the induction agents that we currently have for our patients. So it's less of a concern. However, if hyperacute rejection does occur, it does lead to irreversible damage leading to graft loss. In terms of acute rejection, this happens within days to weeks or months, usually involves your cellular or humoral, so T-cell, B-cell immunity. Reversible damage is possible if managed appropriately early on, and definitive diagnosis is confirmed by biopsy. Chronic rejection is a little trickier. This happens months to years after the transplant. There's a lot of multifactorial pathophysiology that occurs, so inflammation, ischemia, and other processes that we may not catch early on. And this usually leads to irreversible damage, so fibrosis and scarring. So the maintenance immunosuppression strategy we usually use is a multi-drug regimen utilizing different mechanisms of actions to prevent this rejection pathway. Usually we start our maintenance immunosuppression strategy immediately post-op, and it's usually for the duration of the life of the graft. So we will pick one of these agents from each of these classes of medication. So one from the calcineurin inhibitor category, one from the anti-proliferative category, and one from a corticosteroid. And here at our center, we usually use tacrolimus, mycophenolate, and prednisone. A lot of side effects are manageable, so in terms of the CNIs, usually there can be neurotoxicity, so headaches, the tremors that occur, and usually these can be managed by decreasing the dose and ensuring the patients are at the goal level in which that our center is targeting. For anti-proliferatives, this has been more of an issue with our patients because many of the side effects occur with the GI side effects where the patients aren't able to tolerate them. So GI side effects include nausea, vomiting, diarrhea. And usually this can be managed by, again, decreasing the dose or increasing the frequency in which the patients take these medications. So for example, if they're supposed to be taking 1,000 milligrams twice a day, we can potentially try to go down to 250 4 times a day to help with managing some of the GI side effects. Corticosteroids with the prednisone, as we all know, there's a lot of side effects, so blood glucose increase, the glaucoma, there's also neural side effects as well. We do try to wean a lot of our patients off the corticosteroids as soon as we are able to, if they fall under certain categories. Now, we had talked about infection as one of the risks in taking immunosuppression regimen, and so I do want to touch upon infection complications and management as well. So most common life-threatening complications of the long-term immunosuppression so infections can occur if patient is over immunosuppressed. This contributes also to graft loss and long-term survival. So this is where immunosuppression gets tricky because too much, they get infection, but too little, rejection can occur. So infections can also increase the risk for post-transplant malignancy, and this is why routine prophylaxis is usually given post-transplant. And the first steps that occur if the patient gets an infection is to reduce or withhold immunosuppression. However, we do need to carefully consider the patient's history. So if a patient is at higher risk of rejection at baseline, we do want to be a little more careful about withdrawing immunosuppression. There are 3 common anti-infection prophylaxis that are usually given, and these are to prevent cytomegalovirus, pneumocystis pneumonia, and thrush. So for cytomegalovirus, the agent of choice is valganciclovir. We usually prescribe this for 3 to 6 months post-transplant. We'll monitor for neutropenia and GI side effects. Pneumocystis pneumonia, common agents we use here is Bactrim or sulfamethoxazole trimethoprim. There are other agents as well if the patient cannot tolerate the sulfa component of the sulfamethoxazole. This is usually given up to 1 year post-transplant. We do want to monitor for hyperkalemia, myelosuppression, and rash. And of course, should not be given in patients with sulfa allergy. And if we want to give alternative agents, we do have to remember that there may be additional testing required. The third common infection is thrush, and here we do use the clotrimazole lozenges. So we dissolve these lozenges 3 times a day after meals, no food or drink for 30 minutes after. We usually start early after transplant and continue for 1 month post-transplant. There have been data showing concerns with clotrimazole as it is an azole antifungal and increasing calcineurin inhibitor levels. However, there's conflicting results from these studies, and generally most studies have found that it does not cause an issue, so we do use that here. And after giving high-dose steroids, we will restart thrush prophylaxis. And that concludes my portion of the presentation, and I'm open to questions. Okay, so the question is, are there ways to determine how the immune system is working, specifically related to the immunosuppressive agents? So we do tacrolimus monitoring, for example, to help determine if the levels are at goal. Is that what you're asking? So we do look at absolute lymphocyte count, for example, as a way to determine immune system function, especially after thymoglobulin administration. So that's one way to see whether the patient's responding appropriately. Yeah, that's one of the major ways that I can think of right now in determining immunosatisfaction.
It used to be a test that was called Immuno. Like it was based on like ATP activity science, and it never worked.
Yeah.
Way to know.
Yeah.
And Silex, it was sold as tons of very expensive tests for us to show the world that it didn't work.
Yeah.
There's nothing.
Well, the data has just been really spotty on some of these alternative methods of determining immune system function. Yeah.
There was another question.
Yes. Is there a point? So the question is there a point in which non-adherence can be managed by IV immunosuppression therapy? I think one of the ways that I can think of in terms of switching therapy is, for example, with tacrolimus, if the patient qualifies, we can switch to belatacept. So belatacept is, if you're doing conversion therapy, patient generally starts coming in once a month. It's every 2 weeks for the first 5 doses, then once a month thereafter, and it has to be done in the clinic. So we are able to then, kind of manage the patients a little more closely in terms of ensuring that they're getting the therapy that they need. But the caveat to that is if they're already non-adherent and they're not showing up to appointments, and now that they're also not showing up to the belatacept infusions, which is once a month, then that also poses a problem as well. Other than that, I can't think of alternative IV infusion therapies for the other immunosuppressive agents. We can do things to help the patient if they're having trouble swallowing. We can switch formulations, like switching to liquid, for example, or switching to sublingual, for example. But the only IV infusion that I can think of is the tacrolimus portion. Okay. Great questions. Thank you, everybody.